And Ask Me Anything with Dr. Twyman. Hope you guys had a great day. I had a day of studying and talking to patients, telemedicine. You know, it's that time of the year to do cardiovascular boards again. So this year it's on vascular diseases, so peripheral arterial disease, AAAs, venous insufficiency, lymphadenopathies, or lymphedema, I should say. We'll also have to study hypertension, which I'm pretty much a good expert at, so that one isn't going to be too challenging. And then also there's diseases of kind of systemic disorders, you know, so different oncology indications to, you know, look at things for patients with vascular issues. And then there's some other things that look at pregnancy and such. So things that I don't see every day at Apollo Cardiology, but no worries. Passed it the previous time, so I'm not too concerned. But I'm going to be head down, hitting the books for the next couple days and take the test sometime next weekend or so. But saw some good questions popping in. Wait for a few more people to join, and we'll start answering those. But probably many of you have seen it. The podcast I did with Dave Asprey has finally dropped last week. Thought it was one of my better ones because I was able to talk about not only circadian biology and some of the biohacking things that I've known for the past few years, but could tie in a lot of the glycocalyx and vascular health topics that I also talk about routinely with my patients. So if you haven't checked that one out, it's one of my better ones. It's a good framework. You know, it's only an hour, so you know, consider looking into it if you really want to know my perspective on how to really live to you know, a long, healthy age. So now I'll answer a few of your questions here. So first question up tonight, somebody says that they got a high ApoB, a calcium score of 43. They're in the mid-50s. What other cardiovascular tests can they request? And they're not on a statin. So you'd want to look at you know, lipoprotein LA. You'd want to look at different vascular inflammatory markers, high sensitivity CRP, LPPL2 activity, myeloperoxidase, your microalbumin creatinine ratio to start. We'd want to know that you have normal glucose tolerance, so an insulin under 8, a HOMO-IR score under 2, an A1C of 5.1 or less. Potentially could do Boston Heart Labs, like if you're a cholesterol, you know, hyperproducer or cholesterol hyperabsorber. So if you're, you know, not interested in statin, intolerant of statin, then that would tell you is ezetimibe a better option than not to consider. And then there's a whole host of things to look at, you know, what's going on with the system now. So carotid intermedial thickness scans, excuse me, ankle brachial indexes to look at, do you have peripheral arterial disease in your legs? That's where I would start with. And then there's other tests I can look at, endothelial health, so max pulse, endopat. That gives you an idea, like, do you make sufficient nitric oxide now so that you're less likely to continue to go down the pathway of laying down more plaque. All right, so hacks or tips for post-ablation recovery. Somebody's on Xarelto for 3 months post-procedure. So I would anticipate if you said that you're on an oral anticoagulant, that it was an atrial fibrillation ablation. Now, the key is, like, do you know the root cause of why you had AFib to begin with? If not, I would start there. It's often a oxidative stress or inflammatory condition. Sometimes it's due to, you know, microvascular disease and not enough nitric oxide to the small blood vessels. Is it sleep apnea that wasn't treated? You know, was it something else that you can, you know, get to the root cause and treat that? But that being said, you know, think about optimizing mitochondrial function. You know, it's your redox potential. So sleep well, so 7.5 to 8 hours of restorative sleep. Don't miss a sunrise. You know, if you're in an area where you don't have a lot of you know, pipes in the ground or things that would cause jump conduction, then grounding at your home would be a good idea outside. High seafood diet, a lot of DHA to help recover. Potentially using red light therapy would be beneficial as well. Is it generally okay to take arteriosil with an anticoagulant and antiplatelet medication? So this is going to be more general. I cannot give medical advice in this type of form, so you would have to ask your own doctors who are prescribing the other agents, is it safe? But in general, arteriosil is a supplement that is a derivative of a seaweed, and there's some other antioxidants that are in it. So there's really no significant supplement drug interactions with it that I'm aware of. But I don't have a lot of patients on anticoagulation in my practice because I don't do a lot of rhythm management anymore. But I have many patients on antiplatelet agents, and I have no concerns with people being on antiplatelets and arterisol. All right. Next question up tonight. Do I have any recommendations for protecting your heart through peri or menopause? Yes. That's often a time where people's vascular risk starts to increase. Their lipids sometimes will modulate. They'll start having lower HDL particles and higher LDL particles. Blood pressure often rises. That may be in part due to issues with nitric oxide availability. So you'd want to do the basics. Make sure you have normal blood pressure, that you have lipoproteins generally less than the 20th percentile, have normal oxidative stress and inflammation markers. But often women start having more issues with their sleep when they start going through perimenopause or menopause. So I don't prescribe it myself, but I have many colleagues that are experts in hormone replacement therapy. But progesterone potentially is useful to help people sleep better if they're waking up in the middle of the night. And then estrogen, if you're having hot flashes or osteopenia, that's a good indication to be on it. There's not great indications from a vascular standpoint to start hormone therapy just for lowering vascular risk, but you may get some added benefit there that your lipids generally stay like they were before menopause, and blood pressure may stay normal as well. So that is something that I definitely will discuss with every patient who's going through those stages of life. Can I tell you or make a video that shows you what I eat in a day for heart quantum health? Be pretty boring, and what I do for myself isn't necessarily what every person needs to do. So I usually kind of give the kind of generic advice is that you do want to know what your maternal haplotype is. So if you've had 23andMe or Ancestry, you can figure that out. Figure out where your original maternal lineage comes from, because that gives you an idea of what diet may or may not work for you. If you're Northern European, keto diets may work, but the key is, where do you live in the world right now and what season are you? So you do want to ideally eat seasonally, and you want to eat in a circadian rhythm, that would help optimize your sleep. So daylight hours are the best time to eat, in my opinion. Not eating 3 to 4 hours before bed is absolutely key. And then, eating enough protein to maintain the muscle mass. So I always shoot for, more than 90 grams of protein a day, but often close to a gram per pound of body weight of protein. It's a combination of red meats, white meats, fish. And then omega-3s. I try to get seafood a couple times a week. I'm monitoring blood levels generally every 4 to 6 months of myself. Generally shooting for an omega-6 to omega-3 ratio of 4 or less, and we'll titrate from there. So pretty boring. I don't have a exact diet I would say I'm following. I mean, it's probably a mix of Mediterranean / paleo. That's probably what I would name it right now. But from a quantum standpoint, think of food as stored up sunlight, and your job of your mitochondria is to basically break that back down into electrons and protons. So eating food that grows in your environment, keeps you in a optimal quantum kind of biology kind of nutrition plan. And then, how do computer screens damage the eyes? Can this be repaired? So your eyes have photoreceptors. Some of them are visual, so that's why you can see me as I'm chatting with you. But many of them are non-visual, and those are sensing wavelengths of light that you cannot perceive. Some you can perceive. But there's a receptor in the back of the eye called melanopsin. There's receptors in the whites of the eye called neuropsin. Neuropsin senses UVA spectrum. Melanopsin senses blue wavelengths. And those different wavelengths come out throughout the day, and that tells your body what time of day it is. That's why when you're outside, naked eyes to the skies, if you wear lenses, you're going to filter out that light from reaching the eyes. So what is the risk of computer screens? Is that they have more blue light than any other wavelength, particularly red. Sunlight is generally balanced wavelengths. So your device may put 4 to 5 times more blue light out of it than sunlight would. And that blue light photooxidizes different receptors. It liberates vitamin A from the opsins, and that can cause issues with your retina. So can it be repaired? Yes, but first get out of the harm's way. That's where these glasses come in. I've been wearing them pretty consistently since 2017. Anytime I'm in front of a screen or if I'm inside and I don't control the lighting situation. That's why I kind of talked about that with Dave Asprey. I said, he was the guy that got me into thinking about it because he was talking about these glasses way back in 2017. So protect your eyes. I mentioned a little bit earlier, I try to eat seafood a couple times a week. The DHA in seafood, 60% of your retina is DHA, 30% of your brain is DHA. The more blue light you get, the more you destroy the DHA. So you're going to have to eat more seafood then. So it does depend on how far the eyes have been damaged. It can be fully repaired. There's times where, you develop enough cataracts, that is not necessarily going to, get better. The goal is to limit the damage and ideally not go to the point where you have to get the lens replaced, because the lens replacements introduce another issue because they're already going to block a certain amount of blue light in different wavelengths. So, and right now in the United States, there's no way that you can get lenses that don't block those wavelengths. So the goal is protect your eyes as best you can by block artificial light, get natural sunlight, eat your seafood. All right. So I think I got through the pre-submitted question. Thank you guys for those as always. Just looking through the questions here. So again, this can't be medical advice here, but somebody says, can you please comment on methylene blue versus nitric oxide? Is it safe to take as a nootropic or stimulant like Adderall alternative? You have to know what other medications the person's on. Are they on an MAO inhibitor? Are they on SSRI? Have they had issues with other antidepressants before? Sometimes it's not a good idea to play with methylene blue. You have to absolutely know the source that you're getting it from. You absolutely have to know what dose to utilize. There is a risk at a certain dose. If you start going over a milligram per kilogram, you might get yourself into trouble. And then there is a dose-dependent curve where methylene blue will inhibit certain nitric oxide synthase enzymes. There's a very good podcast a couple months ago with Dr. Scott Scherr, Scherr, and Dr. Nathan Bryan that discussed that particular topic. I had actually asked them to get together to discuss that because I've been hearing that in the kind of the biohacking world that methylene blue affects nitric oxide, and obviously if nitric oxide is very important for vascular health, well, you don't want to do things that are going to work against you. But like any good biohacker, if you're taking things, you should be testing to is it causing issues with nitric oxide? So I have salivary nitric oxide test strips from various companies. Make sure those are good. Make sure it doesn't affect blood pressure, doesn't affect arterial elasticity. There's multiple devices that look at pulse wave velocity or how stiff the arteries are. There's some home devices that can do that, but the one I use in the office is called the Max Pulse. And then look at different biomarkers of nitric oxide availability. So ADMA, SDMA, urine microalbumin creatinine, uric acid, homocysteine, make sure those are all normal. Can it help as a nootropic? In some people, yes. It is somewhat of a dose-dependent effect for it, but it helps the mitochondria in the brain tissue make energy without having to need oxygen around to do that. So it's an electron donor, and the name of the game is that it's collect more electrons than you lose to the environment. So methylene blue can speed up energy production in the mitochondria. So it's interesting, but you definitely have to talk to your doctors about is it right for you. This is actually on my board review right now. So do autoimmune disorders affect the heart? Yes. Typically rheumatoid arthritis, lupus, scleroderma, antiphospholipid antibody syndrome, those are probably the bigger ones that do. But Hashimoto's is probably the most common one I see in practice. So anytime your immune system's turned on and there's different interleukins, cytokines, different inflammatory markers that are produced, those compounds can damage the endothelial glycocalyx and the underlying endothelium. So think of it that it basically breaks the force field and it's much more likely that lipoproteins get retained in your artery walls than going forward. So autoimmune disorders are something I always check for. If I suspect that's the driver for the vascular disease, then if you can't improve it with certain lifestyle interventions, then that's when you need a rheumatologist to check it out and discuss what potentially other treatment options you may be benefiting from. Question, are there nitric oxide gummies that are as effective as the nitric oxide slow release lozenges? The answer is no. Any of the gummies, they will have generally some type of sweetener in it that then will basically make the product not actually work. And anything that has sugar will impact the nitric oxide nitrate reducing bacteria in the saliva. So anything that's a gummy would work against producing nitric oxide. So the lozenges have been studied to actually release nitric oxide, and then when swallowed, they help the body make nitric oxide more effectively. So use the products that have actually been shown to work. Somebody says, what lifestyle changes can help autoimmune disorders? It's going to be optimizing your vitamin D, for greater than 60 without supplementing, getting optimal sleep, 7.5 to 8 hours a night. It's going to be potentially grounding to help lower inflammation, and often just trying to get away from the things that are driving autoimmune issues. Sometimes it's gluten for some people. Sometimes it's going to be non-native EMF. So if you live in an area where there's a lot of Wi-Fi, Bluetooth, 5G, that non-native EMF is going to affect your mitochondria and affect your immune system. So you have to kind of get to the root cause. It's low redox potential. It's something in your mitochondria is affecting, and you got to figure that out. Question, how does swollen ankles and legs connect to the heart's functioning? Can it be reversed? Sometimes it's associated, but it's not always. So you need more of a detailed history of what's going on, what medications potentially the person's on, what surgeries have they ever had, if they had any, kind of procedures on the lower extremities. That would all play a role in it. But if it's both legs and it's swelling all day long, then potentially it might be an issue with the heart or the liver or the kidneys. If it's that ankles are swollen or legs are swollen just during the daytime, but they're better after you sleep and you've elevated them, then it's often venous insufficiency. Now, if it's due to heart failure, where the heart isn't pumping well, and you have heart failure reduced ejection fraction, or you have heart failure with preserved ejection fraction, then you got to try to support the heart's functioning with different medications and supplements, and then the swelling will tend to improve. But yes, it potentially can be reversed, but generally I get to the root cause first. I think those are the main questions so far. Sorry, I seem to be losing my voice more chronically now, and I'm working on trying to improve that, so bear with me. You're very welcome. All right. Well, I might be preserving my voice a little bit and also get back to the studying. I'll be done with this board review as of next Monday, so I'll be back usual time, 6 p.m. Central Time. Yeah, I know it's a holiday. I will be out of the office, but I'll be available for anything if anybody needs me for Apollo or through social media. They always can ping me on social media here. The podcast with the Asprey was a good one. If you haven't had a chance to check it out, started off talking about light, talked about photobiomodulation, talked about the glycocalyx, so a lot of my favorite topics. And I think Dave was a little bit impressed that I knew a lot of the stuff, and so I actually got a good compliment that he really called me like the biohacking cardiologist, and I used to unofficially call myself that back in 2017 or so when I started thinking about going on Instagram. Eventually changed it over to my name, Dr. Twyman, so people knew who I was. But it was good to get some feedback from Asprey that he thought I knew enough biohacking stuff to stand pat and have a one-on-one conversation with him about this stuff. So hope you guys have a great week. Thank you as always for your time and attention, and I'll be back next Monday. Thanks.